I'm 50 years old. I live in Black Mountain, North Carolina. I have to admit, I live in a really pretty place. Running helps me be healthier, physically focused on being better, improving my strength, improving my stamina, improving my cardio, improving my range of motion. All of those things that help me just enjoy life more. Helps me sleep better at night. In 2014, it had been a couple of months. I was feeling fatigued, and I was doing a lot of running at the time, and I was really starting to gear up into more longer distance running. But I was feeling more zapped than usual, and I know that sounds like that's a lot, but it was something that I certainly should have been able to withstand. So by October, it hadn't gone away. I was still feeling crummy, and I went to the doctor to see if I had the flu. They told me enough to say, we need you to go talk to my buddy who's a hematologist. And so on January 15th of 2015, I went in and actually I ran 15 miles that morning before I went to the oncologist. And he told me that I had cancer. My name is Kenny, and I was diagnosed with multiple myeloma.
Multiple myeloma is a cancer of a cell called plasma cells. And plasma cells are cells that live in the bone marrow, and their job is to make antibodies. And that's a good thing for us. Now, the way we get such great antibody diversity, meaning we have protection against lots of different organisms or bugs, is that the DNA in a plasma cell is flexible. So that flexibility is a good thing, but sometimes that flexibility turns on a gene that shouldn't be turned on, or turns off a gene that shouldn't be turned off. And what that means is that it's no longer controlled by the immune system. It starts to grow on its own and is not shut down like a normal plasma cell may be shut down. And that growth contributes to lots of other complications associated with myeloma, like bone disease, anemia, renal failure, or other complications of myeloma. So there are genetic instances of multiple myeloma, but they are relatively uncommon. Now, if there is a first-degree family member or a second-degree family member that has myeloma, then your risk does go up, but it doesn't really go up appreciably. Most cases are sporadic cases that occur randomly. What you often see in a myeloma patient early on is a presentation with recurrent infections because you've lost that normal broad antibody protection.
So my primary care physician, sister-in-law, passed of multiple myeloma just a couple of years before I was diagnosed. He was primed to look for things that might have led to that conclusion. And so I was fortunate that he ran that test because it is a special to determine the M protein existence, that myeloma protein. It takes a separate panel. It had a pretty sizable effect because they did a PET scan in order to determine how much damage had been done, or if any damage had been done to my bones. And it was fairly significant. I have bones through my head, and collarbones and sternum, lower ribs, scapulas. I have 2 compression fractures in my back. I've got a lesion in my hip.
Yo! So Kenny and I have known each other since he was in high school and I was in college. Back then we were different ages and now we're the same age. I don't know how that works. And we've been buddies now, 30 some years. It's a long time. If you put Kenny in a room with any 50 people and asked anybody in the room, point to the healthiest guy in the room, they would point at Kenny, right? He's shaped like a yield sign. He's a long distance runner. He's an amazingly fit guy. All that's true, and he has multiple myeloma.
When I first met Kenny, he was 43 years old, and he came to us mostly because he was concerned about the potential for a plasma cell disorder. And when he saw us, he was straddling that intermediate area between smoldering and symptomatic multiple myeloma. That borderline really has to do with whether or not there's evidence of organ damage. But he had evidence of organ damage and so started on therapy with a 3-drug combination that has been probably one of the most common ones that we've used now, and then went on to an autologous transplant.
I think at first it just didn't settle in. It settled in probably a few weeks later when they determined the extent of the damage that had been done to me. I think being afraid is not the right thing. I wasn't scared of dying, but I think I was just more concerned about letting my kids down, letting my family down, because there were things that I hadn't, mistakes I made in my life that I hadn't made up for, or there were things that I hadn't done yet that I meant to do. It was always on the agenda, helping them resolve challenges that they have and will have in their lives, and me not being around. So that was a worry. It's still a worry.
One of the first dichotomies, if you will, in terms of treatment is the patient fit enough to undergo an autologous transplant? And what that really means is their own stem cells. So it's really high doses of chemotherapy with a rescue using their own stem cells. The one that we do most commonly in myeloma is autologous transplant using your own cells. And so for patients that are potentially transplant eligible, they would typically get a 3-drug combination using a medicine that is a proteasome inhibitor, which is the waste basket of the cell, if you will.
So initially, the plan was to prepare me for a bone marrow transplant, a stem cell bone marrow transplant. And so leading up to that, I had to prepare my body, which means that I needed to reduce the instance of the myeloma within my plasma cells. And in order to do that, they gave me a cocktail of very common, for myeloma patients anyway, very common chemotherapy with a steroid. They harvested my stem cells over about 4 days. They froze them. And then about 2 weeks later, they gave me a really powerful dose of another chemotherapy to wipe out my immune system over the course of several days while I was in the hospital.
So shortly after we heard Kenny was sick, several of us decided we wanted to rally around him in every way we could. It was financially devastating, of course, and it was also emotionally devastating and scary.
So in between the time when I had my stem cells harvested and when I went into the hospital to have the bone marrow transplant down at Emory, my friends put on a benefit. They had a local establishment, a local pub called the White Horse, and they stepped up. Some amazing friends and musicians came in and did something that they weren't asked to do. They helped.
We played a bunch of music and we raised a bunch of money and we supported Kenny, and I think Kenny was deeply moved to see how loved he was. But the ripples from something like that just keep going.
They called that the Benny for Kenny. And I love the fact that they just made something really serious and emotional super stupid and silly. And it was emotional. It was beautiful.
So it didn't put Kenny in complete remission, but he did get a remission. His disease has remained at very low levels for 5+ years now. And so between the transplant and the maintenance that we put him on, his disease has been well controlled. I mean, he's doing all the things he wants to do and more.
I'm an advocate. I'm the director of a nonprofit, Throwing Bones, that also advocates for people with diseases. So, but I've seen the progress that has been made in an insanely short period of time. So, yeah, we're going good places.
As with the rest of the cancer field, the explosion of immune-based therapies has really had a pretty significant impact on myeloma. But what I think we're most excited about now are really two technologies. The first is a CAR T-cell. And a CAR T-cell is basically taking your own T-cells out and then programming them to go after a specific receptor on the myeloma and then giving those cells back. What we're struggling with is how long that is going to last, because other diseases that use this CAR T-cell based approach have actually a cure plateau. We've not seen that yet in myeloma, but it's the beginning of the revolution. The second area that we're really interested and excited about is called bispecific antibodies, or T-cell engagers. And what they are, basically, is an antibody. And on one side of the antibody, you bind a T-cell, and on the other side of the antibody, you bind a myeloma cell. And what you do is you bring them right next to each other, and that T-cell that may have been shielded from the myeloma previously because of the bone marrow and all those things that we mentioned before is now right next to its target and says, that's it, I got you now, and kills it. And so that approach really is quite interesting, quite effective also. So those two technologies I think are really exciting and have the opportunity to sort of totally change the landscape in myeloma. You know, Kenny was confronted with a tough diagnosis at a very young age, and it didn't slow him down a bit. And I think that sort of tenacity is what you want from your medical team if you've got myeloma. It is a new day. We have lots of new treatments. There's no reason to keep doing what we did 30 years ago, but at the same time, tried and true does often deliver really good outcomes. And so find a good team, be comfortable with that good team, and boy, if I had a clinic where everybody was like Kenny, life would be easy.
Look at you. What an awesome community comes out on a night like this.
I hope that what people will see from my story, from the experience that I've had, and the experience, the life that I've created, I guess, with the help of a lot of good friends and family, is that there is a tomorrow in some shape, form, or fashion. Sometimes it just takes taking the first step in order to continue living. You got to get up, and then you get to take the second one and the third. It gets easier. And I think that for all of our faults, all of my faults, I'm an example of that.